So increased read index is classically associated with, so it is associated with chronic bronchitis. Okay, so what is this Reed's index? Okay, Reed's index is one important parameter which you will see whenever patient is having chronic bronchitis, where you are going to see two things. Okay, one is gland and wall of the airway. Okay, so whenever you have any patient coming to you with COPD, so you are going to see the gland and the wall. Okay, gland and the wall. Usually the gland is small and the wall is big. Okay, so here, now what happens here is this read index will be less than 0.4. Okay, whenever there is an acute exacerbation, the gland goes for hypertrophy. Okay, when the gland goes for hypertrophy, what is going to happen? The gland size increases than the, almost equal to the wall size, and this read index is significant whenever it is more than 0.52. Okay, whenever it is more than 0.52, it is significant. Okay, so this is called as Reed's index. Okay, so the Reed's index is a parameter which is used to assess patients with chronic bronchitis. Okay, it is significant if it is more than 0.52. Okay, 0.52. So this is Reed's index. Okay, now coming to the next question, which are the drugs used for smoking cessation? All of the above. Okay, which of the following features favor emphysema rather than interstitial fibrosis? So here, which are the following is favoring? Hello. Infusion ஆரம்பிச்சிட்டேன் 8 யூனிட் ஸ்டாண்ட் கொடுத்துருங்க. ஓகே 3 cc per hour வந்து infusion. Okay, sorry. So which are the following favors emphysema? First is it is going to be decrease in the FE1 by FEC. Okay, FE1 by FEC. Next is TLC will increase and peak expiratory flow rate will decrease. Okay, so these are the parameters which has to be seen in emphysema patients rather than interstitial fibrosis. Okay, rather than interstitial fibrosis. Okay, in COPD patient with low SpO2 at rest, best management option is, it is low flow oxygen. Long term therapy with low flow oxygen. Okay, long term therapy with low flow oxygen. Emphysema presents with all except, it is pink puffers, right? So cyanosis is absent. They have barrel shaped chest associated with smoking, type 1 respiratory failure. Okay, then so patient is a young patient, hyperlucency is in the lower lobe of the lung, pan-acinar emphysema. What should be the answer? Alpha 1 antitrypsin phenotyping should be done. So that is the very important thing. Okay, the patient is found to have positive C-ANCA. He is also noted to have alpha 1 antitrypsin level 7 micromoles per liter. PFT reveals which is the most commonly associated phenotype. It's going to be PIS phenotype. Okay, PIS phenotype. So this is actually a big history. I will tell you the positive things around. 75-year-old man. Okay, oxygen dependent for the past 2 years, smoker. Okay, he has shortness of breath when walking and stops every few minutes to catch breath. Okay, and otherwise patient is having lot of history. The patient oxygen saturation is 95% on 2 liters of oxygen. 6-minute walk test is performed. It is around 230 meters. Okay, he is an obese man with BMI of 30 and V's is present on examination. A chest radiograph was performed which shows hyperinflation, and otherwise nothing is significant. FE1 by FEC ratio is 23%. The patient is planned for surgery, need pre-operative evaluation. Okay, which of the following is the best way to predict this long-term prognosis? It is B. So it is going to be Bode index. Okay, so the patient is planned for surgery, and what is the thing which is required to recognize his mortality rate or survival? BMI, obstruction, dyspnea, and exercise tolerance. Answer is B. Okay, answer is B. 69-year-old man, COPD, smoker, okay, and exercise tolerance is stops multiple time when walking, grade 3 MMRC, 3 liters of oxygen, okay, saturation is 95%. Okay, so these are the positive things here. His PFT is shown here, which shows FE1 by FEC ratio of 0.21. You can perform an assessment of the patient's COPD severity. Which of the following is not a criterion used in combined COPD assessment? The use of supplemental oxygen. So what they have asked actually, what are the components of ABCD? So in ABCD, what we have? One is MMRC scale, CAT questionnaire. Then we have GOLD criteria and exacerbations. Okay, so this is again a testing. Okay, so use of supplemental oxygen is not a part of this classification. Okay, a 50-year-old man, smoker, not a smoker, productive cough for the last 3 years. He denies any smoking history or sick contacts. He tries to exercise, but it's limited by his cough. So this was normal. He has been recently telling history of progressive shortness of breath and cough, and has been discharged on bronchodilators, okay, and short course of steroids. The pulmonary function test is shown below. Okay, what is your diagnosis? This is the history. So if you see here, the FE1 by FEC ratio is 60%, and bronchodilator response is not there. So we are ruling out asthma. Okay, and patient has a productive cough for last 3 years. It should be chronic bronchitis. Okay, so by definition, what is bronchitis? Patient having cough for more than 3 months for 2 consecutive years. That is the definition, and they are asking what is the definition. Okay, the patient is having chronic cough for last 3 years, signifies it is more towards chronic bronchitis. Okay, chronic bronchitis. 62-year-old man complaining of progressive shortness of breath, worsening of cough, and increased sputum production for the last several days. He is a smoker with history of COPD on fluticasone, salmeterol, albuterol. His exercise tolerance is limited to getting out of bed, significantly worsened than the previous one, which is he can walk around 200 meters. His physical examination is remarkable for a respiratory rate of 42 breaths per minute, saturation 79%, diffuse bilateral wheezing, and prolonged expiratory phase. So typical of COPD, the patient is coming to you. Okay, this is the ABG. Okay, and pH is acidosis, PCO2 is 116. So respiratory acidosis is there. And if you take the FE1 by FEC percentage, 40%, DLCO is 23%. The patient is intubated and treated with steroids and inhaled bronchodilators, and he is extubated on day 3. Okay, what about this patient's pulmonary function test is most suggestive of COPD? So they are simply asking what is the feature of obstructive lung disease. In obstructive lung disease, what is going to happen to the DLCO? Usually normal. In emphysema, it decreases. and FE1 by FEC ratio decreases. Answer is going to be both A and B. Okay, both A and B. So here DLCO is decreased. So patient is having features of, actually what they mean is the patient is having features of emphysema. Okay. A 59-year-old man, COPD, smoker. Despite continuous smoking, he has been stable for the last 1 year on medications. Okay. The patient tried to quit several times, but has not stopped for more than 4 days. His brother is also a smoker, recently diagnosed with advanced small cell carcinoma of lung. Your patient is concerned for his health and wants to know what he can do to increase his lifespan and reducing his chances of developing lung cancer. Which patient group is associated with highest mortality after lung volume reduction surgery? Option. So I told you that contraindication for lung volume reduction surgery is FE1 of less than 20% and homogeneous or diffuse emphysema. So answer should be A. Okay. I told upper lobe emphysema you can go for lung volume reduction surgery. One is correct, but other one is wrong, right? Here both are correct, right? So what you will prefer? And both are correct, you will prefer the both are correct, right? Answer is A. Okay. Answer is A. So upper lobe emphysema is an indication for surgery, right? So you have to go for surgery. A 69-year-old man, COPD, stopped smoking 6 months ago. Okay. And prior to this, he had 50 pack year smoking history. Okay. He has a minimal exercise tolerance. Okay. And stops multiple times when walking short distances. His MMRC scale is grade 3. Okay. He is on 3 liters oxygen. Okay. And multiple lung medications. His last COPD exacerbation has been 2 years ago, for which he was treated with a short course of steroids and antibiotics. The possibility of lung transplantation is raised, but the patient refuses. He has no other medical conditions, and physical examination reveals saturation of 95% on 3 liters per minute, oxygen on nasal cannula. Okay. You review the patient current vaccination history. Which of the following is the most accurate concerning vaccines in COPD patients? So here, which is more appropriate? So here they have given flu vaccine and pneumococcal polysaccharide vaccine should be administered only in COPD patients of 65 years or old. Okay. So flu vaccine, actually irrespective of any age, you have to give yearly. Okay. And pneumococcal polysaccharide vaccine, okay, in a COPD patient should be administered routinely after 65 years of age. Okay. But if he is a young patient, okay, if he is a young patient, okay, then one dose should be given once he is diagnosed with COPD, and followed by 65 years you have to go for second dose. Okay. But for any patient being a COPD after 65 years it is mandatory. Okay. So based on here, which option tells that every year you have to give flu vaccine? E says every year you have to give flu vaccine. Okay. Apart from this, pneumococcal polysaccharide vaccine should be given after 65 years of age. Okay. So that is the most appropriate option among all the 4 options. Okay. So vaccines are contraindicated in severe COPD is wrong. Flu vaccines are recommended yearly in COPD patients alone is wrong. If you want 2 options, means you can take this option also as correct. Okay. Otherwise, as a single option, this is wrong. Flu vaccine and pneumococcal vaccine are administered only in COPD patients 65 years or older is actually wrong. The flu vaccine is administered yearly in COPD patients. The pneumococcal polysaccharide vaccine is given after age of 50 years is wrong. Okay. It is administered after 60 years of age. Okay. So when you come to pneumonia, in pneumonia there will be something like more than 65 years, mandatorily you have to give vaccine. And there are certain indications like cochlear transplant patients, immunocompromised patients. In those patients, you will give 1 dose whenever the patient is being diagnosed, and after that 65 years you will give one more dose. Okay, that is different indications are there, but we don't want to confuse it here. Okay, so this is about what happened. Okay. So this is about COPD. Okay, so we'll go into the next topic. The next topic is going to be bronchiectasis. Okay, so bronchiectasis again one of the important topic. Okay, even in our day-to-day practice, you will be getting to see most of the patients coming as bronchiectasis. Okay, so it is again going to be a very vital topic for your day-to-day practice. Apart from this, you are going to have patients or questions in exam which is more bronchiectasis based. Okay, so coming to bronchiectasis, so bronchiectasis. Okay, what is bronchiectasis? Bronchiectasis is abnormal permanent dilatation of medium sized airway. Okay, so it is abnormal permanent dilatation of medium sized airways. Okay, that is the definition of bronchiectasis. Okay, so any patient who presents with abnormal permanent dilatation of the medium sized airway is going to be called as having bronchiectasis. Okay, here we have to see three important things. The first one is broncho arterial ratio. Okay, what is bronchoarterial ratio? As I told previously, you have bronchus and you have artery. Okay, whenever the bronchus enlarges in size and if the ratio is more than 1, okay, then it is going to be indicating that bronchiectasis. The second important thing is lack of tapering. Okay, so whenever you take in a normal airway, the normal airway will taper towards the peripheries. Okay, instead the tapering is not present, the airway is dilated all through, then it is going to be bronchiectasis. Then the third point is the airway is visible within 1 centimeter of pleura. Okay, it's visible within 1 centimeter of the pleura. So what happens here? This is the pleural lining, for example, and your airway is almost touching the lung border. Okay, that is going to be called as airway visible within 1 centimeter of the pleura. Okay, so these three things also define bronchiectasis. Okay, bronchiectasis. If you take bronchiectasis, this bronchiectasis is more common among females. It is more common among females and it is predominantly seen in lower lobe left side. It is predominantly seen over the left lower lobe. Okay, if you take bronchiectasis, there are three types of bronchiectasis. One is cylindrical type. Okay, cylindrical type means the airway is cylindrical like this. Okay, it is cylindrical or tubular in type. Tubular in type. Cylindrical or tubular in type. Then second important thing is varicose type. Varicose type means it is like this. This is varicose type. And the third one is going to be cystic type. Okay, cystic type. Okay, it has lot of cyst. Okay, that is going to be cystic type. Out of this, the most common type is going to be cylindrical type or tubular type. Cylindrical type or tubular type. The most common type is going to be cylindrical type or tubular type. Okay, what is happening in bronchiectasis? Okay, one second, I'll just see what this. Okay, so here in bronchiectasis, it is going to be an initial inciting event in the form of infection. Okay, this infection will lead to inflammation. Then what is going to happen? There is going to be airway obstruction. This airway obstruction will result in bronchiectasis. So what is happening here? The patient is going to have infection, inflammation, airway obstruction, bronchiectasis, and this cycle keeps on repeating. Okay, and further worsening of bronchiectasis is going to happen. So there should be an inciting infection. Infection leads to inflammation. Inflammation leads to airway obstruction, and that in turn leads to bronchiectasis. Okay, so this is keep on repeating in this patient. Okay, it keeps on repeating in this patient. Okay, so this again, as we saw here, this is based on the bronchogram called Reed's bronchogram. In Reed's bronchogram, we are going to divide, as we saw earlier, three types. Okay, cylindrical, varicose, and cystic. Okay, out of this, the most common one is going to be the cylindrical type. Okay, most common type is going to be cylindrical type. Okay, you can divide this bronchiectasis into primary bronchiectasis and secondary bronchiectasis. In primary bronchiectasis, you have the first condition called as Mounier-Kuhn syndrome. What is this Mounier-Kuhn syndrome? Mounier-Kuhn syndrome is a condition characterized by tracheobronchiomegaly. Okay, here in this picture you can see here the trachea is enlarged. Okay, the trachea is enlarged, the bronchus is enlarged. You can see here this is tracheobronchiomegaly, and based on this you can see here the air space is also enlarged. Okay, this is called as tracheobronchiomegaly seen in Mounier-Kuhn syndrome. Okay, then the second condition where we are going to have one condition. You can see this picture. In this picture you have lot of white rings. What are these white rings? Cartilage rings. Okay, we know that trachea till your medium sized airways we have full cartilage followed by incomplete cartilage, right? Yesterday we saw, right? இப்ப இங்க வந்து cartilages இருக்கு. What happened here? இங்க இந்த white structures இருக்கா? இல்ல இல்லையா? So here it is characterized by congenital absence of cartilage. Congenital absence of cartilage. And this congenital absence of cartilage is called as William Campbell syndrome. William Campbell syndrome. Okay, William Campbell syndrome, where there is congenital absence of cartilage ring. Okay, cartilage ring. Okay, then third condition of it. Okay, so third condition is going to be yellow nail syndrome. Okay, yellow nail syndrome. So yellow nail syndrome is a condition which is characterized by pleural effusions. So if you see, this is a constellation of events. Pleural effusion is present, lymphedema is present. So patient is going to have both upper limb edema and pedal edema, but it is a non-pitting edema because lymphedema, and the patient is also going to have bronchiectasis, and patient is also going to have yellow nail. So this is going to be a constellation of events called as yellow nail syndrome. Okay, yellow nail syndrome, and the patient is going to have yellow nails. Okay, so this is how the patient is going to have. The patient is going to have yellow nails. Okay, like this. Okay, yellow nails. Okay, so if you see the characteristically, they will have yellow nails all over. Okay, and this is going to be called as yellow nail syndrome. Next is these patients are going to have another associated condition which is going to be called as cartaginous syndrome. Cartaginous syndrome. What is cartaginous syndrome? As I told yesterday, it is characterized by SBI, which is sinusitis, bronchiectasis, situs inversus, and associated with infertility, which is due to asthenospermia. Asthenospermia. This has been asked in the exam again in INICET. Okay, asthenospermia. Okay, then the third syndrome which is associated with this condition is going to be Young syndrome. Young syndrome. Young syndrome also has same features like our SBI. Okay, apart from this, here there is going to be infertility, and this infertility is characterized by azoospermia. Azoospermia. Okay, azoospermia is where there is going to be immotile sperms are going to be present. Immotile sperms are going to be present. Okay, that is called as azoospermia. Immotile sperms are present. Okay, that is called as Young syndrome. Okay, this is the cause for your congenital causes or primary causes for bronchiectasis. Okay, then we have secondary causes or acquired causes. Okay, in secondary causes or acquired causes, we have infections. Okay, so lot of infections, bacterial infections can cause bronchiectasis ultimately, and the most notorious one is going to be our Mycobacterium tuberculosis. Apart from this, we have Staphylococcal aureus infection, Bordetella infection, MAC infection, and viral infections like HIV, adenovirus, and influenza. Adenovirus and influenza. Okay, infections like Mycobacterium tuberculosis, Staph aureus, Bordetella, MAC infections, and viral infections. Okay, then next is endobronchial obstruction. Endobronchial obstruction. Okay, so if you take this as an airway, there is an obstruction within the airway, endobronchial obstruction, which causes or prevents the secretions from getting cleared up, and because of this, what is going to happen is the patient is going to have airway dilatation. Okay, so what are the conditions? The conditions are ABPA, which we will discuss later. For time being, write it as ABPA. Alpha 1 antitrypsin deficiency, hypogammaglobulinemia. Hypogammaglobulinemia. Okay. Cystic fibrosis. Cystic fibrosis. So these are common causes for bronchiectasis. Okay, common causes for bronchiectasis. Okay. Then next is, these are common causes of bronchiectasis. Okay. Then next is a patient presents with, copied, right? Okay. So patient presents with right middle lobe obstruction. Okay. So here this is the airway, and here there is a lymph node enlargement. Okay, lymph node enlargement. Whenever there is a lymph node enlargement, what happens? This lymph node enlargement will compress the airway. When it compresses the airway, what is going to happen is the secretions which are present here will start building up and they cannot be drained out. Okay, and whenever this right middle lobe obstruction is present, right middle lobe obstruction due to TB lymph nodes, it is called as Brock syndrome. Brock syndrome. Okay, right middle lobe obstruction due to TB lymph nodes is called as Brock syndrome. Right middle lobe obstruction due to TB lymph nodes is called as Brock syndrome. In this image also you can see here, in this image what is happening here? You can see a haziness over the right middle lobe or near the right middle lobe, and this is called as Brock syndrome. Okay, this is called as Brock syndrome. Okay, this is called as Brock syndrome. Right middle lobe obstruction by lymph nodes in TB patients is called as Brock syndrome. Okay, then next is another condition where the patient is going to have right middle lobe bronchiectasis, right middle lobe obstruction with MAC infection, Mycobacterium avium complex. Okay, especially in elders who have decreased clearance. Okay, so what happens here is these patients will have decreased airway ventilation or airway clearing. Because of this, the secretions gets heaped up, and secondarily there is going to be MAC infection. Okay, and where you get this? This is usually seen in patients like this. Okay, so this is based on a character in a novel by Oscar Wilde. Okay, where the British ladies used to wear tight upper outfit, where it will be like, if you see here, there is a narrowing here, okay, in the abdomen part. So they will have tight stitchings here. Okay, so what happens whenever they cough? Okay, the dress will not allow them to cough. Okay, so what they do is they used to suppress the cough. Okay, and because of the suppression of the cough, what is going to happen is the secretions will get collected, and there is secondary MAC infection, and they are going to develop bronchiectasis. And based on this character, they label this condition as Lady Windermere syndrome. Lady Windermere syndrome. So this is based on the novel character. They label this condition as Lady Windermere syndrome. Lady Windermere syndrome. Lady Windermere syndrome. Okay, so this condition you can see here, there is a middle lobe haziness here. Okay, so if you see this one, This indicates that the person is suffering Lady Windermere syndrome. Okay, right middle lobe bronchiectasis. Okay, right middle lobe bronchiectasis known as Lady Windermere syndrome. Okay, then you have another one condition which is going to be, as we discussed previously also, this is traction bronchiectasis. So exactly they don't include this into the classification of bronchiectasis. Okay, so this is usually seen in patients with pulmonary fibrosis. Pulmonary fibrosis. Okay, so because there is a fibrosis in the lung, okay, what is going to happen here is this fibrotic area will pull the airway. Okay, whenever the fibrotic area pulls the airway, what happens is the airway will go for dilatation. Okay, dilatation, and because of the pull in the surrounding area, and this is called as traction bronchiectasis. Okay, so in contrary to the routine clinical feature of bronchiectasis, these patients are going to have only dry cough. They don't have productive cough. Okay, only dry cough. Okay, so because of this, there is very scanty or very minimal sputum will be there. So lot of times it is not diagnosed as bronchiectasis. Okay, and they will not have any history of recurrent infections. Recurrent infection. Okay, so this is called as traction bronchiectasis. This is seen in patients with pulmonary fibrosis where you are going to have dry cough with no history of recurrent infections. Okay, recurrent infections. Okay, then you have another one condition called celiocytopathy or celiocytopturia. Celiocytopturia. What is this celiocytopturia? Okay, so whenever there is a viral infection, these viral infections, what they do is they go and destroy the cilia here. Okay, destroy the cilia here. So whenever they destroy the cilia here, what is going to happen is the cells are going to have a smudged appearance. Smudged appearance. And this smudged appearance is called as celiocytopturia. Okay, celiocytopturia. Okay, with here and there they will have one cilia. This is called as celiocytopteria. Okay, so yes, I told you this is going to be a recurrent event which is happening in patient with bronchiectasis. So what is going to happen? The patient is going to have either a congenital defect or patient is going to have airway infection and inflammation. Okay, which is going to result in bacterial colonization and infection, and this will damage the bronchi, and that is going to cause airway dilatation, and this sequence is going to happen repeatedly. Okay, ultimately patient landing up as bronchiectasis. Okay, what is the clinical feature of bronchiectasis? Okay, if you take the clinical feature of bronchiectasis, if you take the clinical feature of bronchiectasis, the patient usually will have purulent productive cough. Purulent productive cough. Okay, this cough has postural variation, increases on lying down posture, Okay, and these patients also will have hemoptysis. Okay, hemoptysis. Okay, so one respiratory condition which is going to present with hemoptysis is going to be bronchiectasis, and these patients are going to have clubbing. Okay, and whenever you auscultate, the patient is going to have bilateral inspiratory crepitations. end inspiratory crepitations are present. Okay, so here whenever you take the patient will tell that copious amount of sputum production which increases on lying down posture, and this sputum production is also called as bronchoria. So in a single day they can produce around 500 ml of sputum. Okay, half liter of sputum, bronchoria. Okay, which has positional variation. On lying down, on lateral decubitors, they will have more amount of cough and sputum production. They will have hemoptysis, clubbing, and crepitation. Okay, so in these patients, if you see the sputum, okay, so previously in wards and all, they will have something called sputum cups. Okay, sputum cups. What the patient will do is patient will spit out the sputums in glass jars. Okay, so if you take the sputum, on seeing the sputum itself, the doctor will identify the condition, because in the lower layer they are going to have pus collection, in the middle layer they are going to have liquid, okay, and in the upper layer they are going to have foam. Okay, and this kind of three things in the sputum is called as three-layered sputum. So three-layered sputum is a classical feature of bronchiectasis. Three-layered sputum is a classical feature of bronchiectasis. So lower down they will have pus, then above they will have liquid, and above they are going to have foam. Okay, this kind of sputum production is called as three-layered sputum production. Okay, three-layered sputum production, which is very classical of bronchiectasis, and this is the three-layered sputum production. Okay, you will have thick sediment in the bottom, then liquid, and above you will have foam. This is going to be called as three-layered sputum production. Okay, sputum production. Okay, and these patients can get secondary infection. Okay, secondary infection, and the secondary infection is more common with Pseudomonas more than Staph aureus. Okay, staphylococcal infection is more common than Pseudomonal. Pseudomonal infection is more common than Staph aureus. Okay, so it is going to be most commonly associated with Pseudomonas. Okay, Pseudomonas, very important. Okay, next is whenever you have bronchiectasis, there are certain conditions which will have low predilection. Okay, low predilection. Okay, so whenever a patient has bronchiectasis and it is going to be upper lobe predominant, okay, more amount of bronchiectasis in upper lobe, then you have to think about CPR. Okay, so the condition is going to be cystic fibrosis post radiation. Okay, then middle lobe bronchiectasis. Middle lobe bronchiectasis is more common with MAC infection. Okay, MAC is Mycobacterium avium complex, and also with tracheobronchiomegaly. Any condition which causes tracheobronchiomegaly, especially conditions like Mounier-Kuhn syndrome. Okay, then lower lobe bronchiectasis. Lower lobe bronchiectasis is more common with aspiration. Fibrotic lung diseases. Hypogammaglobulinemia. So these are associated with lower lobe bronchiectasis. Then coming to central bronchiectasis. Central bronchiectasis is seen only in one condition, which is going to be your ABPA. Hello. So it is associated with ABPA. Central bronchiectasis is associated with ABPA. Okay. So what is ABPA is allergic bronchopulmonary aspergillosis. Allergic bronchopulmonary aspergillosis. Okay, that is associated with central bronchiectasis. Okay, central bronchiectasis. Okay, so what is the investigation you are going to do? The investigations which are available for your patients with bronchiectasis, the first is spirometry. Spirometry is going to show obstructive lung disease pattern. In obstructive lung disease pattern, we are going to have FE1 by FEC ratio decreased. Okay, and DLCO here is going to be normal. Okay, next is HRCT. Okay, HRCT is the investigation of choice. HRCT is the investigation of choice. Okay, whenever you do HRCT, what you get to see is you get to see like this. What is this called as? I will show you here. Okay, so here you're going to have lot of cystic spaces like this, which looks like dilatation of the airspace. So it is going to be bronchiectasis, and you can see here what is this called as signet ring sign. Okay, you are going to have like this. So you have a thickened dilated airway with the vessel nearby, which is of almost equal in size, which is going to be called a signet ring sign. Then what you are going to get? Tram track sign. So what are the other tram tracks you can get in medicine? Ankylosing spondylitis, which glomerulonephritis, type 2, MPGN type 2, Sturge-Weber syndrome in brain. Okay, so these are the common tram tracks you can get in medicine. Okay, apart from this, where you can get spaghetti sign or live spaghetti sign? In retina, tomato splash appearance you can get where? CMV. Okay, spaghetti sign you can get in broken or displaced breast implants. Okay, there you will get spaghetti sign. Okay, then what are the other signs? Okay, so where you will get panda eye sign? Sarcoidosis. Okay, in gallium scan you can get in sarcoidosis. Wilson's disease you can get. Okay, Wilson's disease you will get panda sign. Okay, where you will get tiger eye sign? Haller-Walden's disease. Okay, due to pantothenate kinase deficiency. Okay, metachromatic leukodystrophy you will get tiger skin sign. Okay, tiger skin sign in the brain. Okay, tiger skin sign. Okay, tigeroid appearance will be there. Okay, where you will get feline esophagus, eosinophilic esophagitis. Okay, so these are few named signs, right? Okay, so then what you can get lot of cystic spaces like this. Okay, cystic spaces like this. Okay, which is going to give you a honeycomb appearance. Okay, honeycomb appearance like this, honeycomb appearance. Okay, and it also can give appearances like this also. What is this one? Tree in bud appearance. Okay, tree in bud appearance. So you can also get tree in bud appearance. Okay, and you can also get bunch of grape appearance. Okay, bunch of grape appearance, tree in bud appearance. Tree in bud appearance, and bunch of grapes appearance. You get lot of bunch of grapes like appearance. Okay, in chest X-ray. Okay, bunch of grapes appearance. Okay, so these are the things which you can get in patients with bronchiectasis. Okay, bronchiectasis, and this is again an important thing which has been asked recurrently in your exams. Okay, recurrently in exams. Okay, what is the treatment? Treatment. Okay, so in patients with bronchiectasis, you have to maintain proper bronchial hygiene with postural drainage. Postural. So the question asked by one person is, why is clubbing is seen in bronchiectasis and not in COPD? Okay, so why bronchiectasis it is seen is, it is an infective condition as such. Okay, whenever there is an infection, okay, with hypoxia, then that infection can cause microembolies, and these microembolies can result in clubbing. Whereas COPD is a chronic obstructive lung disease, it can also have clubbing. Okay, can also have clubbing whenever there is chronic hypoxia. Okay, but not in early phase or initial phase of COPD. But in late phase, you can develop clubbing. Okay, so even in tuberculosis, conventional teaching is clubbing is not seen, but clubbing is seen in even in tuberculosis. Okay, so bronchial hygiene with proper postural drainage. Okay, so what you have to do is you have to give proper chest physio to drain the sputum out or secretions out. Okay, then you go for antibiotics based on the culture sensitivity profile in that hospital or region. Okay, then what you can do is you can go for nebulization with gentamicin. Nebulization with gentamicin. Okay, in cystic fibrosis patient especially. Okay, then you can go for long term beta lactam and macrolide treatment. Okay, so this is given at around 6 months to 9 months, and they are going to be given as immunomodulatory effect. Immunomodulatory effect. Okay, then you can go for aerosolized DNAs. What is this aerosolized DNAs? Okay, this is a mucolytic agent. Okay, so here in bronchiectasis patient, there will be thick sputum production. In the thick sputum liquefy panna, you go for aerosolized DNAs. Okay, and you can go for resection of lobe. If it is not working, then you can go for lung transplantation. Lung transplantation. That is the ultimate endpoint of treatment in bronchiectasis. Okay, lung transplantation. This is very, very important. Okay, so here, based on the patient profile, the antibiotic regimen will vary. Okay, the antibiotic profile will vary. Okay, then here you have another one instrument which is going to be used bedside. Okay, and this is called as Acapello. Acapello. Okay, you have another one method of draining the secretion called as HFOV. What is HFOV is high frequency oscillatory vest. Oscillatory vest. Okay, so these two options are available to drain the secretions. Okay, so what happens here is high frequency oscillatory vest. So here what happens here is, so you can go for postural drainage like this. You make the patient to lie down, cup your hand and give tap over the back to drain the secretions. Okay, then what you can do is you can go for these kind of vest. Okay, high frequency oscillatory vest, which is worn by the patient. So when it is the patient is going to wear this, and you can see the vibrations happening there, and this vibrations will set forth the lung into series of motion. And whenever there is a series of motion here, what is going to happen? The secretions are going to get drained out. So you can see the vibration there. Okay, this is called as high frequency oscillatory vest. And you have next one more thing, which is going to be called as acapello. Acapello is a small whistle-like thing. Okay, where the
In healthy
patient is going
lungs,
to
mucus is produced to trap and get rid of
the
foreign
patient is
particles or
going to have
bacteria.
secretions in the lung in bronchiectasis like this. Okay, now what happens is you are going to tell the patient to blow air. Okay, நம்ம normal whistle மாதிரி இருக்கும். So in the normal whistle like thing, when you blow air, what will happen? Your lung will go for vibrations, right? The same thing happens here. Whenever there is a secretion getting collected here, that is going to be resulting in damage to the cilia and narrowing of the airway. Now what you are going to do is you are going to give this device, which is called as acapello. When you give this acapello, what will happen? This acapello will set your airway into vibrations. Okay, when it sets the airway into vibrations, what is going to happen is this vibration will create a kind of rift in the airway, and this will break the secretions, and it will let you to drain the secretions by coughing out the secretions. Okay, and this is also a method which is being tried in patients with bronchiectasis. Okay, tried in patients with bronchiectasis. Okay, so what is the complication of bronchiectasis? Bronchiectasis. So this bronchiectasis sometimes will lead to pneumonia, and this pneumonia can be a necrotizing pneumonia. Necrotizing pneumonia. Okay, and these patients can develop abscess. Okay, necrotizing pneumonia can lead to lung abscess. Okay, and this lung abscess can become a empyema. Okay, and these abscess can go to different areas as metastatic abscess. Okay, and results in generalized septicemia. And whenever bronchiectasis is there for a longer duration, it can also result in amyloidosis. So these are the complications of bronchiectasis. Okay, these are the complications of bronchiectasis. Okay, so with this we are finishing bronchiectasis. Again, bronchiectasis is a common topic in day-to-day life, and it is going to be again a common topic for your exam also. Okay, so if they are going to give you a picture like this and they are going to give 3 or 4 options, what will be your answer? I'm not giving you the option. 4 options is being given. What you will think? I told you upper lobe predominant bronchiectasis is seen in CPR, cystic fibrosis, post radiation. Where is the bronchiectasis or airway dilatation? Upper lobe. So the condition is going to be cystic fibrosis. Okay. Most common type of bronchiectasis, cylindrical type of bronchiectasis. Mid-lung bronchiectasis is seen with A. So Mycobacterium avium complex is also called as Mycobacterium avium intracellular. So answer is A. Investigation of choice for bronchiectasis, HRCT. Most common cause, okay, leave this. Bronchiectasis is most common in which lobe? Left lower lobe. Not a CT finding in bronchiectasis. Gracie paving pattern. A 35-year-old female is referred to your clinic with recurrent upper respiratory tract infection. She has long-standing sinus congestion, wet cough. She denies dry eyes, dry mouth, parotid gland enlargement. Coarse crepitations are heard over the left lung base. Okay, and so So otherwise everything is negative. Okay, negative. Urine analysis is negative for hematuria and otherwise unremarkable. The patient having FE1 by FEC is 56%, TLC is 87%, DLCO is 63%. What is the most likely diagnosis in this patient? Primary ciliary dyskinesia. Very good. It is primary ciliary dyskinesia. So patient is having SBA like symptoms, right? Mostly like a SBA like symptoms. Okay. So patient is having, what is patient is having? Sinusitis, bronchiectasis, wet cough, and you can see here the heart is, this is an CT scan. The heart should be like this, but it is like this. That is dextrocardia is given. Okay. So this is a case of primary ciliary dyskinesia, mostly Carter-Jenner syndrome. Okay, Carter-Jenner syndrome. A 68-year-old female referred to your clinic with productive cough for 6 months. Okay, review of system is positive for 3 months history of night sweats, weight loss. She is given 4 months of azithromycin by her primary care doctor for refractory bronchitis. She denies any history of smoking or tobacco chewing. The patient was working in a clothing factory, and she had a recent travel to country like Mexico. Okay, and otherwise patient has kyphoscoliosis, coarse rails in all lung fields, and there is a late systolic murmur radiating to the axilla with an audible click. So this is not so significant for the patient present history, but this is the history where patient is having history of productive cough for 6 months and patient is having symptoms of night sweats. Okay, this is the PFT. Okay, PFT shows FE1 by FEC 86%, almost normal. DLCO is decreased. Okay, and this is the X-ray and this is the CT scan. Okay, so if this is the option, what would be the most appropriate next step you will be doing? So patient coming to you with history of weight loss, night sweats. Okay, and patient cough is refractory to treatment. Okay, what you will do? You will go for, you will try to rule out TB. Okay, the sputum specimen with AFB smear and culture. What would be the appropriate initial treatment plan for this patient? If you see here, this patient is having some haziness here, some haziness here. Okay, and if you see here, here also some kind of haziness is there. Okay, and if you see here, 86% DLCO is decreased. Okay, so some infection which is going to involve the interstitium. Okay, and which is going to cause night sweats and weight loss. So this is more towards Mycobacterium avium complex, because middle lobe is getting involved, middle part of your lung is getting involved, and interstitial pattern is there. So it is going to be Mycobacterium avium complex. So what is the treatment for Mycobacterium avium complex? Pharmacology, microbiology, it is RACE. Okay, rifampicin, azithromycin or clarithromycin, ethambutol. So what will be your best option here? Best option here, D. Okay, whenever MAC infection is there, you'll go for RACE, rifampicin, azithromycin, clarithromycin, ethambutol. Okay, that is the treatment for Mycobacterium avium complex infection. Mycobacterium avium complex infection, that is the treatment. Okay, that is the treatment for Mycobacterium avium complex infection. Okay, so next topic is cystic fibrosis. So if cystic fibrosis is covered in pediatrics, I will skip and go to the next topic. Covered, I'll skip it. So why we are skipping topic is, the reason is, okay, so we have to finish in time. Okay, another thing constant is time for writing. Okay, so I always see these 2-3 rows. Okay, whenever I see these 2-3 rows, when they are completing, they are like markers for rest of the crowd. Okay, so I feel that so everyone is writing. Okay, but what happens here is
ingredients சொல்றேன். அரிந்த வெங்காயம், பூண்டு, இஞ்சி பூண்டு விழுது, மிளகாய்த்தூள், மல்லித்தூள், கரம் மசாலா பவுடர், சோம்பு பவுடர், உப்பு, கொத்தமல்லி, கருவேப்பிலை, எண்ணெய், சீரகத்தூள், தேங்காய், பச்சைப்பயிறு ஊற வைத்து வாழ்த்துக்கள் புகழ்.
வாழ்த்துக்களா?
கன்ஃபியூஷன் யாருக்கிட்டையும்
இதை யார்கிட்ட சொன்னாலும் ஒண்ணும் பண்ண முடியாதுங்க. ஏன்னா
உங்களுக்காக
so the reason is my thing is I have to complete the topic because before 7:30. Okay, because it's like a mixed thing. Few people are telling that we have to go for far away place, we have to finish by 7:30. Okay, at the same time it should be written. Okay, and I should not leave any topic left unattended. Okay, so there is like how much pressure you have, that much pressure I also have. Okay, my mind always thinks that I have to complete all the topics before 7:30. Okay, so it means that class will end at 7:30. Okay, so 7:30 if I have to finish means I have to rush here and there. But the thing is, this PDF they will be uploading in your app, I think so. Okay, so if anything is left over by chance, you can even copy it from there. Okay, but mostly the reason we go little fast here and there is the urgency in completing the topics. Okay, if it is left over, then it will be like one more online session or 1 hour, 2 hour. Again, everyone will not be able to attend that particular time. So those kind of difficulties are there. Okay, so don't worry. Okay, so we will try to cover whatever possible is there. Okay, so again, if you take respiratory medicine, it is again one of the dry topic. Okay, where we have nothing conceptual. Okay, the reason nothing is conceptual there is it is all about COPD. COPD, what is there to tell clinically? If you ask me, there is nothing to tell clinically. Okay, patient will come with மூச்சு வாங்குது, இருமல் இருக்கு, சளி இருக்கு, then patient will come with increased respiratory effort. என்ன பண்ண போறோம்? Again treatment. Okay, நீங்க ஆக்சிஜனை முன்னாடி கனெக்ட் பண்ணிட்டு நெபுலைசேஷனை பின்னாடி கனெக்ட் பண்ணா யாரும் உங்களை கேட்க போறது கிடையாது. நெபுலைசேஷனை முன்னாடி கொடுத்துட்டு ஆக்சிஜனை பின்னாடி கனெக்ட் பண்ணீங்கன்னா யாரும் உங்களை கேட்க போதே கிடையாது. There is no proper flow chart. But the thing is, there are certain protocols for treatment. Okay, which is actually protocol only, but not followed in practice. Okay, so you cannot ask a pulmonologist why you have started salbutamol inhaler. Okay, he will tell that my patient is comfortable or improving with salbutamol, but the protocol says that you have to go for LABA with low dose inhaled corticosteroid. Okay, if you take any physician will refer the patient to a physician or a pulmonologist. That patient is a known case of asthma on inhaler steroids that will affect the baby. Okay, but what physician will do is continue the same inhaler because inhaler will not do anything to the baby. Okay, so there are a lot of misconceptions. So here, whenever you take any disease, even if you take interstitial lung disease, diagnosing interstitial lung disease is a very tough thing. Okay, because you have to definitely do a CT scan to diagnose. Okay, which will be not affordable for most of the patients. Okay, and if you go to drug treatment, again you have drugs which will cost, one drug will cost 300 rupees to 350 rupees, and everyday patient has to take tablet. Again, it is not feasible, but those things should be definitely followed as per protocol, and that will be a question in your exam again. Okay, so protocols, you have 2-3 subjects which are little conceptual, or 2-3 chapters in medicine which are conceptual. One is definitely cardiology. Okay, second is endocrinology. Third, you have nephrology. These 3 chapters are conceptual. And if you go to GIT is everything straightforward. Okay, for example, in gastro it is everything straightforward. When you go to hepatology, it is more conceptual. Okay, so otherwise if you take rheumatology, if you take respiratory medicine, it is everything straightforward. Okay, you have to do this thing, then you have to do this thing. That is the one thing where patient is going to have complaints which is same everywhere except for few things. For example, interstitial lung disease, the only clue in your question paper will be, or only clue the patient will be giving is exertional dyspnea. உட்கார்ந்து இருந்தா நல்லா இருக்கு, நடந்து கொஞ்சம் தூரம் போனா மூச்சு வாங்குது. So here there are two differentials. One differential is going to be cardiology, okay, or cardiac cause. The second differential is going to be interstitial lung disease. So here in these places only you have to juggle and make a diagnosis. Okay, so interstitial lung disease, again one of the least touched topic in entrance exam. Okay, but one topic which is the bread and butter of your pulmonologist. Okay, so this condition is going to be involving the interstitium. Okay, so if you take the lung, what happens normally? Oxygen is going to go here and CO2 is going to go here. Okay, so this is the gaseous exchange happens, but what happens here is there is going to be inflammation. Okay, inflammation of parenchyma which occurs due to TGF beta more than PDGF. The inflammation is mediated by TGF beta and PDGF. Okay, so this is the thing which is happening in the interstitium. Okay, so this is a parenchymal inflammation and fibrosis also. Fibrosis. Okay, fibrosis. Okay, so this condition is characterized by inflammation of parenchyma followed by fibrosis. Okay, this condition is more common among females than males, and the common age group is around 40 to 60 years of age. 60 years of age. Okay, common age group is going to be 40 to 60 years of age. Okay, so this is one important thing which is not so commonly seen in young patients, relatively young patients. Okay, so what will be the clinical feature of the patient? Okay, the clinical feature will be predominantly the patient is going to have exertional dyspnea. Exertional dyspnea. Okay, and the next thing is the patient is going to have chronic dry cough. Chronic dry cough. Okay, so this is chronic dry cough. Okay, if this condition is going to be chronic except in few conditions. Okay, the few conditions where it is going to be acute is going to be cough. Write it as cough. We will see what is cough later. And another one is Hamann-Rich syndrome. In these conditions, it is going to be acute. Otherwise, it is going to be chronic. So, Hamann-Rich syndrome is also called as AIP. Okay, we will see later what is AIP. Okay, then next is these patients are going to have dry cough and these patients are going to have clubbing. Okay, interstitial lung disease, one very well-known reason for clubbing. Okay, and whenever you auscultate the patient, you will get crepitations, and these crepitations are called as Velcro crepitations. What is Velcro crepitations is, you have in your shoes and all Velcro, right? When you remove that Velcro, you will get one sound. That kind of sound will be there. Velcro crepitations can be seen. Okay, then these patients can also have pleuritic type of chest pain. Pleuritic chest pain. Okay, pleuritic chest pain. So these are the clinical features what the patient is going to present with. Okay, what the patient is going to present with. Okay, so whenever you classify the patient of ILD, there are different ways of classification, and this tree is a classification tree of ILD. Okay, classification tree of ILD. Okay, so this ILD usually is going to be idiopathic in nature. Idiopathic in nature. Okay, so in idiopathic we have chronic and acute or subacute conditions. In chronic condition we have the first one, which is called as IPF. Okay, idiopathic pulmonary fibrosis, which is also called as usual interstitial pneumonia. Usual interstitial pneumonia, which is also called as idiopathic pulmonary fibrosis. Okay, then the second common disease. Okay, so this is the most common interstitial lung disease. Okay, most common interstitial lung disease. The second common lung disease is going to be NSIP. Okay, which is called as non-specific interstitial pneumonia. Second most common. These two conditions are chronic conditions. These two conditions are chronic conditions. Chronic conditions. Okay. Then coming to acute condition, we have two conditions here. Acute or subacute condition. In acute or subacute condition, we have acute interstitial pneumonia, or also called as Hamann-Ridge syndrome. Okay. Then we have cryptogenic organizing pneumonia. Cryptogenic organizing pneumonia. Okay. This is again an acute to subacute condition. Okay. Then we have a rare condition, which is going to be lymphoid interstitial pneumonia. Lymphoid interstitial pneumonia. Okay. Then we have collagen vascular diseases associated with ILD. So here we have rheumatoid arthritis, Sjogren's, polymyositis, dermatomyositis, scleroderma, which we have already seen. Okay, so it is going to be associated with scleroderma, polymyositis, dermatomyositis, rheumatoid arthritis, Sjogren's. Okay, then it is associated with pneumoconiosis. Pneumoconiosis. So all pneumoconiosis are associated, especially asbestosis, silicosis, and berylliosis. These three conditions are more commonly associated with interstitial lung disease. Then we have smoking related ILD. In smoking related ILD, we have three conditions. The first one is called as RBILD, respiratory bronchiolitis associated interstitial lung disease. The second one is PLCH, or pulmonary Langerhans cell histiocytosis, and the third one is DIP, or desquamative interstitial pneumonia. DIP or desquamative interstitial pneumonia. Okay. Then apart from this, we have certain conditions which are rare causes, or we don't know why this occurs also, and this is called as weirdos. Which is called as weirdos. Okay, weirdos. Okay, what are the weirdos we have? Okay, in weirdos we have LAM, okay, which is called as lymphangiomyomatosis. 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 Second one, in weirdos we also have Langerhans cell histiocytosis. Okay, even though it is associated with smoking, it is also a weirdos. Okay, the next is PAP. What is PAP? Pulmonary alveolar proteinosis. Okay, pulmonary alveolar proteinosis. Okay, so these are the conditions which are associated with interstitial lung disease. Apart from this, we have drug-induced interstitial lung disease, which we will see later. We have, one second, I will see, just see. So we have drug-induced, so we have separately one table. So there I will discuss the drug-induced interstitial lung disease. Okay, so these are the causes of interstitial lung disease. Okay, then the question which is asked in exam is, what are the conditions which causes upper lobe predominant interstitial lung disease? Upper lobe predominant interstitial lung disease. upper lobe predominant interstitial lung disease. Okay, so whenever they ask upper lobe predominant interstitial lung disease, the causes can be lap brush. Okay, lap brush. What is the upper lobe conditions are LCH. Okay, in our rheumatology we saw ankylosing spondylosis. Then we saw psoriasis. Okay, then next is berylliosis. Okay, then radiation. Then next is ABPA. Okay, then sarcoidosis. Then hypersensitive pneumonitis. Hypersensitive pneumonitis. These are conditions which are going to predominantly involve the upper lobe. Upper lobe predominant conditions. Okay, if you take lower lobe, lower lobe predominant conditions are first is idiopathic pulmonary fibrosis, NSIP. DIP is desquamative interstitial pneumonia. Connective tissue disorders other than your ankylosing spondylitis and psoriasis, other conditions are lower lobe predominant. Then next is drug induced. Okay, then asbestosis, and here you can also add silicosis. Okay, so these are the causes for upper lobe and so it is upper lobe predominant condition, lower lobe predominant conditions. Okay, upper lobe and lower lobe predominant conditions, and this is a very important MCQ. Okay, very important MCQ. Then coming to investigations. Okay, so here the first thing is you're going to go for 6-minute walk test. Since this condition causes exertional dyspnea, what you're going to do is you are going to mark 2 points of 100 meters distance, and you are going to tell the patient to walk this distance. When the patient starts walking this distance, okay, he is going to walk over 6 minutes, and we are going to see his exercise tolerance. Okay, exercise tolerance. Okay, normally the patient will not have at rest. He is normal at rest, but on exertion, what happens? He starts desaturating, because while he is walking, there is going to be VQ mismatch, which causes desaturation. Okay, this is one thing which you can do in this patient. And the second thing is going to be bronchoalveolar lavage. Okay, bronchoalveolar lavage. Okay, so what is bronchoalveolar lavage? You will put a bronchoscope, you will take the washings, and you will see in the microscope for any specific cells are present or not. Okay, or you can do for anything like CD4 count, etc. Okay, then next is spirometry. Spirometry is going to show typically a restrictive pattern where the patient is going to have normal or increased FE1 by FVC, but DLCO is going to be decreased. Okay, So this is very, very important thing. Okay. And if you take the bronchoalveolar lavage, one important thing in this bronchoalveolar lavage, what they can ask in exam is going to be, they are going to ask you CD4 CD8 ratio. CD4 CD8 ratio. Whenever the CD4 CD8 ratio is more than 2, okay, it indicates sarcoidosis. Sarcoidosis. Okay. Whenever the CD4 CD8 ratio is less than 1, okay, less than 1, then it indicates hypersensitive pneumonitis. Hypersensitive pneumonitis. This is one important point in bronchoalveolar lavage. Bronchoalveolar lavage, you get CD4 CD8 ratio more than 2, sarcoidosis, and less than 1 in HSP. Okay, it's a very, very important thing. Otherwise, all the other things I will tell in the respective diseases. Okay, then what you get to do is you are going to do a HRCT. You are going to do a HRCT. So HRCT is the investigation of choice. Investigation of choice. Okay. So whenever you do HRCT, what you're going to do is you are going to see the pattern of involvement. Okay, say the pattern of involvement. You get to see lot of patterns in HRCT. Okay, so what you can get is you can get reticular pattern with honeycombing. Honeycombing. Okay, honeycombing. Or you can get a pattern like this, which is going to be called as ground glass appearance. Ground glass appearance. The ground glass appearance. Okay. Then next what you're going to see is you're going to see this pattern, which is called as reverse halo sign. Reverse halo sign. Okay, reverse halo sign. Okay. And here also you can see the honeycombing here. Honeycombing. Okay. Then what you can see is you can see here, you can see a pattern like pulmonary edema. Okay. So this is consolidatory pattern. Consolidatory pattern. So these are different patterns you get to see in the CT scan. Okay. Whenever you have like reticular pattern with honeycombing, then it is more towards usual interstitial pneumonia. Usual interstitial pneumonia. Ground glass appearance is usually seen in non-specific interstitial pneumonia. Okay. Then reverse halo sign is seen in cryptogenic organizing pneumonia. Again, honeycombing already we saw. Then consolidation like pattern is seen in acute interstitial pneumonia. So individual places I will tell you what are the patterns can be seen, but this is the common pattern you can see here. Okay. So what is the treatment? Okay. So if you take this as an interstitial lung disease, we don't have any marked drugs to say this will work very nicely. Okay. The pathology is because of two things. One we saw TGF beta, another one is PDGF. Okay. So what you can give is you can go for a anti-TGF beta and anti-PDGF. Okay. In anti-TGF beta, we have a drug called pirfenidone. And we have an anti-PDGF drug which is called as nintedanib. Okay. Okay. These are the two drugs available. Okay. Two drugs available. Okay. So you would have known these drugs during COVID. They gave in COVID patients also because they wanted to prevent fibrosis. They were giving in COVID conditions, but we don't know how much useful this drug was. Okay. So, but they were trying this drug. Otherwise, you can give only symptomatic treatment in these patients and no other specific drugs available for interstitial lung disease. Okay, coming to the first disease here, the first disease is going to be usual interstitial pneumonia. Okay, this usual interstitial pneumonia is also called as idiopathic pulmonary fibrosis. This is the most common interstitial lung disease. It is usually seen in elderly males and smokers. Elderly males who are smokers. Elderly males who are smokers. This condition is going to have poor prognosis. Poor prognosis. Poor prognosis. So what is the investigation you can do? You can go for a chest X-ray. Okay. The chest X-ray is going to show lot of thin lines like this. You can see the chest X-ray here, lot of thin line like this, and this is called as reticular opacities. Reticular opacities. Reticular opacities. Okay, reticular opacities. Okay, and in CT scan, you see lot of lesions like this, and this is going to be honeycombing. Honeycombing. Okay, reticular opacities and honeycombing pattern. Okay, so you can see here bilaterally their reticular pattern is seen here. Okay, what is the gold standard investigation? Gold standard investigation. Gold standard investigation is going to be lung biopsy. Lung biopsy. Lung biopsy. Okay, so this is the treatment investigation options available, and these patients are going to show honeycombing pattern. Okay, honeycombing pattern. So if you come to treatment, again there is no specific treatment here. What you can try is you can try oxygen therapy. So that forms the baseline treatment in interstitial lung disease. Then you can try steroids. Okay, with or without cyclophosphamide and azathioprine. Azathioprine. And one more important thing here is very important thing which we discussed in last class, I think so. Okay, which connective tissue disorder it is associated with? It is associated with rheumatoid arthritis. It is associated with rheumatoid arthritis. Okay, rheumatoid arthritis. Okay, so this is one important thing with regard to your UIP, okay, or IPF. Okay, UIP or IPF. The second important disease is going to be called as NSIP. NSIP. What is NSIP? It is non-specific interstitial pneumonia. Non-specific interstitial pneumonia. Okay, this is the second most common interstitial lung disease, and it is associated with connective tissue disorder. Okay, connective tissue disorder. As such, this condition has good prognosis. Good prognosis. Okay, good prognosis. Okay, and the investigation what you're going to do is HRCT. Okay, so you would have seen these glasses, right? Normal glasses, if you see how it will look, the other side will be seen. But whenever you use this tinted glasses, it will be seen but not exactly seen, right? So whenever you see the sky, whenever you see with the plain eyes, and then you use this glass and see the sky, you see that tinted appearance, right? The same thing, normally lung will look like this, but when you see in NSIP, you get a tinted appearance like this. Okay, இருக்கிற மாதிரியும் இருக்கும் இல்லாத மாதிரியும் இருக்கும். Okay, so that is called as ground glass opacity. Okay, and you will get to see these ground glass opacities here. You can see here, this is ground glass opacity and this is a normal lung. Okay, that is what we were getting in COVID also. COVID le romba common ground glass opacity. Okay, so you can see here, this is a normal lung, but here you have ground glass opacity. Okay, lung mariye irukku but exacta lung theriyala, that is called ground glass opacity. Whereas if you see here, what is this pattern? Honeycombing pattern. Here we are not getting that much of ground glass opacity. Here we are getting only honeycombing pattern. Okay, so this is called as ground glass opacities, and ground glass opacities is seen in non-specific interstitial pneumonia. So you are going to get ground glass opacities. Ground glass opacities. Okay, ground glass opacities. Okay, this is the thing which you are going to get in patients with non-specific interstitial pneumonia more commonly. Okay, what is the treatment? Again, it is going to be steroids. Okay, then next is drugs. Okay, drugs. Okay, in drugs we have to remember few things. Okay, so what are the few things we have to remember? 1A, 4B, 2C and M. Okay, so what is the A? Amiodarone. Okay, then for B, beta blockers, bleomycin, busulfan. Okay, then bromocriptine. Okay, so in C you have to remember carmustine, and C, cyclophosphamide. Okay, and you have to remember 1M. The M is methotrexate. Okay, 1M is methotrexate. Out of these causes, what is the most common drug which can cause pulmonary fibrosis? It is methotrexate is the most common drug which can cause pulmonary fibrosis. Okay, so amiodarone, beta blockers, bleomycin, busulfan, bromocriptine, car and cycle, methotrexate. Okay, so out of this, methotrexate is the most common drug which will cause pulmonary fibrosis. Okay, next we are going to the next condition which is going to be called as AIP. Okay, AIP. What is AIP? AIP is acute interstitial pneumonia. Acute interstitial pneumonia. Okay, acute interstitial pneumonia. This acute interstitial pneumonia is also called as Hamann-Rich syndrome. Okay, Hamann-Rich syndrome. This Hamann-Rich syndrome is characterized by acute onset, diffuse alveolar damage. Okay, in which condition we have the diffuse alveolar damage? ARDS. So this condition mimics ARDS, and this condition has poor prognosis with a mortality rate of 60%. It is highly worse prognosis is present, and it is going to be causing a mortality rate of around 60%. Okay, so what you are going to get, you are going to do a chest X-ray. The chest X-ray will show again like a pulmonary edema, bat wing appearance. bat wing appearance. Okay, and if you see here, you get consolidation, solidified lung consolidation. Okay, so consolidation is seen in these patients, which looks like ground glass opacities, but exactly it is a consolidation. Okay, consolidation. Okay, so this condition has a very poor prognosis, and treatment is supportive treatment, and mostly the patient will go for mechanical ventilation. Mechanical ventilation. Mechanical ventilation. Okay, mechanical ventilation. So this is condition which presents like ARDS, but it's an interstitial lung disease. Okay, so usually what will have in ARDS, it is going to be more of alveolar involvement, but this is a condition which is going to involve the interstitium. Okay, then the last next important condition is going to be BOOP, or it is also called as BOOP or COP. COP is cryptogenic organizing pneumonia. Okay, cryptogenic organizing pneumonia. This condition is also called as BOOP and COP. Okay, this condition is characterized by the patient will present like pneumonia like illness. Pneumonia like illness. Okay, where if you take the lumen of the airway, there is going to be proliferation of granulation tissue. Proliferation of granulation tissue. Tissue in bronchioles. Bronchioles. Followed by the patient is going to have chronic interstitial inflammation. Chronic interstitial inflammation. Okay, so initially they are going to have a lumen involvement, followed by they are going to have chronic interstitial involvement. Okay, interstitial involvement. Okay, so this condition is going to be presenting or starting like pneumonia, followed by it is going to be having interstitial inflammation. Okay, interstitial inflammation. So based on this, we have two kinds of diseases. Okay, one is called constrictive bronchiectasis. Constrictive bronchiectasis pattern. Another one is restrictive fibrosis pattern. So this is going to present in two ways, either as a obstructive lung disease or a restrictive lung disease. Okay, so in constrictive bronchiectasis, the patient will not respond to steroids, and it is steroid unresponsive. Okay, whereas restrictive fibrosis pattern responds to steroids. So you can give steroids as treatment here. Steroids as treatment here. Okay, and the next step is investigation. You can go for HRCT. Okay, HRCT. In HRCT, what happens is, this is the lung. Okay, lung. This is the heart. So what is going to happen is, this is the air space. Okay, they are going to have air space consolidation with bronchial wall thickening. Bronchial wall thickening. Okay, so these patients are going to have air space thickening with that is bronchial wall thickening or air space thickening with surrounding area consolidation. Surrounding area consolidation. Okay, surrounding area consolidation. Whenever you see this one, how it looks like is, it will have a appearance which looks like this. Okay, which looks like this. Okay, so this is the thing which you get to see here, which looks more or less like this. Okay, more or less like this. So you get a air space consolidation, okay, with the bronchial wall or your airway thickening will be there, okay, like this, okay, and it will resemble like this. What is this one called as? It looks like a area of inflammation surrounded by normal areas, okay. So here you get to see, sometimes you get to see an appearance like this. Like this, okay. This is called as Atoll sign. Atoll sign, okay, where you get multifocal areas of patchy consolidation, which is called as Atoll sign, okay. Multifocal areas of patchy consolidation, okay, multifocal areas of patchy consolidation, okay. So there are different areas of consolidation, okay, multifocal areas of patchy consolidation, okay. That is called as Atoll sign, which looks like this. You can see here, this is what looks like one island, this is another island, like this, okay. Or sometimes this can be more organized, okay, looking like this, okay, looking like this, okay. So this is going to be called as reverse halo sign, okay. This is called as reverse halo sign. This is called as reverse halo sign. Reverse halo sign, okay. So there are two signs here. One is called Atoll sign, the other one is going to be called as reverse halo sign. Reverse halo sign. If you see in this image, what you get to see here, you see lot of areas of patchy consolidation along with reverse halo sign seen, okay. So again, treatment, there is no specific treatment here, okay, no specific treatment here. So again, treatment, if you're going to go for, it is going to be steroids. Okay, so this is the findings in patients with steroids, especially whenever it is going to be a restrictive pattern. Okay, so this is the treatment of COP or BOOP. Okay, so we are going to next one important thing, which is going to be smoking related interstitial lung disease. One question last 2 years from this smoking related LD they are asking. Okay, so again, especially in Langerhans histiocytosis, one question comes regularly in the last 2 years. Okay, so here we have three conditions associated. Okay, the three conditions associated are going to be, the three conditions which are associated is going to be desquamative interstitial lung disease, okay, or desquamative interstitial pneumonia. The second one is respiratory bronchiolitis associated ILD. The third one is going to be pulmonary Langerhans cell Histocytosis. Pulmonary Langerhans histocytosis. Okay, so if you take this desquamative and respiratory bronchiolitis associated ILD, okay, this condition is going to present with eosinophilic granulomas. Eosinophilic granulomas. Okay, these conditions are going to present with eosinophilic granulomas. So how it is going to present is, it is going to be more nodular pattern. Nodular pattern. Okay, and these nodules will join together. These nodules will join together to form thick-walled cyst. Thick-walled cyst. Thick-walled cyst. So that is going to be the pattern. Okay. Now what happens here is, if you do a biopsy, okay, and if you see the biopsy, what happens in biopsy is, these patients in the biopsy, okay, in the biopsy, you will have lot of respiratory cells, Along with the respiratory cells, you get to see lot of brown color patches like this. Brown color patches like this. Okay. In the respiratory cells. Okay. These brown color patches are called as smokers macrophages. Smokers macrophages. Okay. These smokers macrophages are going to give appearance like copper coins. So it is also called as copper penny appearance. Copper penny appearance. Copper penny appearance. Copper penny appearance. Okay. This is seen with mostly with RBALD and desquamative ILD. Okay. Desquamative ILD. Okay. Whereas if you take pulmonary Langerhans histocytosis, this condition is usually seen in young males. Okay. It is going to be presenting with involvement of upper lobe predominant cyst. Upper lobe predominant cyst or cavity. And these cyst and cavity will coalesce to form pneumothorax. So in interstitial lung disease, if they're going to ask pneumothorax, okay, there are only two answers in your question. Okay, one is going to be your pulmonary Langerhans histocytosis. Another one we will see little later. Okay, so there are only two options or two answers possible. One is going to be pulmonary Langerhans histocytosis. Okay, so this is one thing which you get to see, and this is seen in the upper lobe. Okay, so it is seen in the upper lobe. So what is these things are? Pulmonary. What is this? Smoking associated ILD. What is this called as? Smokers macrophages. What you see here? Lot of cyst and cavity. Okay. Sometimes what happens? This cyst and cavity will rupture to form pneumothorax. Okay. So pneumothorax is associated with pulmonary Langerhans histocytosis. Okay. Very, very important thing. Okay. Very, very important thing. So this is going to be more of RBALD, okay, where you get to see smokers macrophages. Whereas here you get lot of cyst. The cyst will break to form pneumothorax. Okay, so this is the thing which you get to see in smoking associated ILD. Okay, smoking associated ILD. Okay, then next condition is going to be pulmonary alveolar proteinosis. Pulmonary alveolar proteinosis. Okay. So in pulmonary alveolar proteinosis, the problem is the patient is going to have antibodies against GM-CSF. Okay. So what is this GM-CSF? Which is required for clearance of surfactant. Okay. So there is going to be altered macrophages. So there is going to be abnormal surfactant accumulation. Surfactant accumulation. Okay. So what is going to happen here is the patient alveoli is getting filled up with milky white material. Getting filled with milky white material. Okay. And if you see in the ball, you will see milky ball in bronchoalveolar lavage. Okay. Milky white ball. Okay. And these is going to be seen in these patients. Okay. So this is because of decreased surfactant clearance causing abnormal surfactant accumulation. Okay. If you see this condition can be divided into 3 types. Okay. The first one is congenital PAP. The second one is acquired PAP. The third one is secondary PAP. Secondary PAP. Okay. So these are the 3 types of PAP you get. Okay. So congenital PAP is due to congenital deficiency of surfactant protein B or due to mutation of a channel called ABCA3 cassette. Okay. So congenital deficiency of surfactant protein B or mutation of ABCA3 will cause pulmonary alveolar proteinosis. In acquired, we have GM-CSF mutation. Okay. So there is a defect in the GM-CSF production resulting in abnormal surfactant accumulation, and this is the most common cause. Okay. In secondary it occurs secondary to certain diseases where lymphatic obstruction occurs, like silicosis, hematological malignancy. Hematological malignancy. There is a protein disorder called lysinuric protein intolerance. Lysinuric protein intolerance. So these are the common causes for your pulmonary alveolar proteinosis. Okay. So what is the most common age group? The most common age group is around 40 to 50 years of age, where they are going to have productive cough. So one interstitial lung disease where there is going to be productive cough is going to be your PAP. Okay, PAP. Okay. So this is one condition which is going to be associated with productive cough. Okay. And this is very, very important clue in your exam. Okay. And these patients are going to present with dyspnea. So they are going to present with dyspnea. Okay. So next is you can go for imaging. Okay. So whenever you go for imaging, the chest X-ray shows bilateral infiltrates, and it also shows a bat wing like appearance, okay, which is called as a reverse bat wing appearance. Reverse bat wing appearance. Okay, reverse bat wing appearance. Okay, so you can see here you can see the reverse Batwing appearance. Okay, so reverse Batwing appearance is seen, not like the regular Batwing appearance seen in pulmonary edema. Okay, and next is you can go for HRCT. What HRCT is going to show? HRCT is going to show crazy paving pattern. Okay, crazy paving pattern. Okay, so what is this crazy paving pattern? Okay, here you are going to have normal areas plus areas with ground glass appearance with septal thickening. Septal thickening. Septal thickening. Okay, so this is what you get to see in patients with pulmonary alveolar proteinosis. Okay, then if you take this patient's ball, the ball will show milky white material. Milky white material. Okay, whenever you take this milky white material and stain it with PAS, okay, they are going to form PAS positive flocculent densities. Flocculent densities. Okay, flocculent densities. Okay, so what you're going to get is you're going to get a milky white ball. Milky white ball. Okay, and whenever you're going to stain it, the staining pattern is going to be like this. Okay, so they're going to have flocculent deposits like this. They will form deposits. Okay, these are flocculent deposits. Okay, so this is called PAS positive flocculent deposits, which is very characteristic of this condition. PAS positive flocculent deposits, which are very characteristics of this condition. Okay, so this is what you get in ball. Okay, ball. So this is going to be very, very important. Okay, then coming to, there is a lot of space. Okay, treatment. Okay, so when you take treatment here, the treatment varies from primary to secondary, but usually you will go for supportive treatment only. Supportive treatment. Okay, supportive treatment. Okay, so whenever you plan treatment, whenever it is a secondary cause, supportive treatment plus treat the cause. Okay, whenever it is a primary condition, okay, you will go for whole lung lavage. Whole lung lavage. That is, every now and then you will wash the lung and take the fluids out. Okay, and you can also go for GM-CSF supplementation. Okay, if there is no response, then you go for lung transplantation. Lung transplantation. If there is no response, you go for lung transplantation. So you go for whole lung lavage with GM-CSF. If there is no response, then you can go for lung transplantation. So the ultimate treatment here is going to be lung transplantation. Okay, so this is the treatment of primary and secondary PAP. Okay, so what you will do is you will put the bronchoscope, you will take the washings. Okay, so when you take the washings, you can take lot of fluid which are milky white in color from the lung. Okay, so these are milky white ball. Okay, and if you see in the microscope, they are going to give you PAS positive flocculent deposits. Okay, flocculent deposits. Okay, next is we are going to see a condition which is asked in last year INICET exam, which is going to be pulmonary lymphangiomyomatosis. Pulmonary lymphangiomyomatosis. Okay, this pulmonary lymphangiomyomatosis is seen in premenopausal women. So the reason is not known. They say it is more because of the imbalance in the hormones. Okay, in the estrogen and progesterone hormone levels. Okay, so it is seen around 40 years of age group. 40 years of age group. Usually the cause is idiopathic, but it is associated with tuberous sclerosis gene mutation. It is associated with TSG mutation. Okay, so when you will suspect, whenever a relatively young female comes to you with emphysema or recurrent pneumothorax, okay, then you will suspect pulmonary lymphangiomyomatosis. Okay, so whenever any young female is coming to you with emphysema and recurrent pneumothorax, then you will suspect lymphangiomyomatosis. Okay, so what are the two conditions which are associated with pneumothorax? One is PLCH, another one is pulmonary lymphangiomyomatosis. Okay, these are two conditions which are associated with pneumothorax. Okay, so whenever the patient is pregnancy accelerates the course of disease. Pregnancy accelerates the course of disease. Okay, so here in any patient who is coming to you with pulmonary lymphangiomyomatosis, it is associated with angiomyolipoma, because if you take tuberous sclerosis, it is associated with angiomyolipoma, and this condition is also associated with angiomyolipoma. What is angiomyolipoma? In kidney, you will have a mass. It's called angiomyolipoma. Okay, and these patients will also have chylous pleural effusion. Chylous pleural effusion. Chylous pleural effusion. Okay, if you take the CT scan, the CT scan will show increased interstitial thickening. Interstitial thickening with bullae and pneumothorax. Okay, whenever you take the lung surface, and if you see, the lung surface will show cystic dilatations. Whenever you see the biopsy shows smooth muscle proliferation because of myolipoma, muscle. Okay, it is going to be showing smooth muscle proliferation. And one thing which is very helpful in diagnosing this patient, it is associated but not specific. If you see the VEGF level, okay, vascular endothelial growth factor, the vascular endothelial growth factor will be more than 800 picogram per ml. Okay, 800 picogram per ml. Okay, so this will be the feature which is seen in patients with pulmonary lymphangiomyomatosis. Okay, this will be the feature which will be seen in pulmonary lymphangiomyomatosis. Okay, then next is, this is again a typical CT scan, shows pneumothorax and large bullae or giant bullae. Okay, what is the treatment? Okay, the treatment here is we go for mTOR inhibitor. What is the mTOR inhibitor? Sirolimus. Okay, sirolimus. If the patient is not improving with medical treatment, then the next treatment option available is going to be lung transplantation. Okay, lung transplantation. Then the last interstitial lung disease. Is going to be lymphocytic interstitial pneumonia. Lymphocytic interstitial pneumonia. Okay, this lymphocytic interstitial pneumonia is a condition, lymphocytic. So it is associated with HIV infection and Epstein-Barr virus infection. Okay, so this is again an uncommon condition, but it is associated with HIV and Epstein-Barr virus infection. And this condition is having close relation with another one, connective tissue disorder. Which one? Sjogren's. It is associated with Sjogren's syndrome. It is associated with Sjogren's syndrome. Okay, here the patient will typically present with parotid gland enlargement, with lymphadenitis. Okay, lymphadenitis. This condition, there is parotid gland enlargement and lymphadenitis due to lymphocytic infiltration. And there is lymphocytic infiltration over the lung also. Interstitial infiltration. Again, the treatment is going to be steroids. It is going to be steroids. Okay, so this is the lymphocytic interstitial pneumonia, which is seen in immunocompromised patients, that is HIV and Epstein-Barr virus, and it is also associated with connective tissue disorder. Okay, so this is about the interstitial lung disease. Okay, and interstitial lung disease, again, one least touched topic in recent years, last 3-4 years, highly they are asking from these areas. Okay, so again, it is very straightforward topic. Which of the following is true regarding idiopathic non-specific interstitial pneumonia? It has a good prognosis. It is seen in relatively young patients, female, and there is going to be ground glass opacities. All of the following are features of interstitial lung disease except exertional dyspnea. Yes, actually cyanosis can be seen in this condition. Clubbing will be seen. It is fine Velcro crepitations. Okay, fine Velcro crepitations. A 68-year-old man, smoker, sleep apnea on CPAP. Okay, dyspnea on exertion. Okay, he is having BMI of 36, Mallampati score 2, bilateral crackers. Okay, this is this report. Okay, this report shows his DLCO is decreased. Okay, and otherwise nothing is much significant. 6-minute walk test again shows desaturation. Okay, desaturation. Okay, what is the major finding in spirometry and lung volumes? It is a, what happened to the TLC here compared to the predicted? It is decreased. Okay, it decreased. Then what happened to the IC? It is also decreased. Okay, so both are decreased with the DLC is decreased. What is the major finding in spirometry and lung volumes? It is going to be truly restrictive disease. Okay, so restrictive disease means usually what will have decrease in the FE1 FEC ratio, decrease in the lung volumes with the DLCO decrease. So this is a truly restrictive disease, because what they mean is it is an interstitial lung disease with exertional dyspnea. A 64-year male, progressive dyspnea on exertion, chest pain, atrial fibrillation. ECG shows, he was undergoing electrical cardioversion and amiodarone was started. Okay, and apart from this, he has nothing significant. That is what kind of pattern here is seen? almost like a honeycombing pattern is seen. Okay, what treatment you would prescribe for him with the intent of being curative? Curative. Lung transplantation. Okay, curative is lung transplantation, right? What pirfenidone and nintedanib will do? It prevent the progression. Okay, what patient is evaluated in pulmonary clinic? What objective parameters would you use to determine the progression of disease? What objective parameter? This DLCO. Okay, so DLCO is a objective because you are giving and patient is expiring out. So whatever is coming out, you are going to measure. So it is going to be direct information. Okay, then what happens here? Patient is going to expire out. Initially, the patient had mild fibrosis. So what happened? The patient had a DLCO of around 50%. As the disease progressed, the fibrosis increased. What will happen to the DLCO? Decreases. 6-minute walk test is again a subjective. Okay, it varies from patient to patient. If a patient is obese, he will not be able to walk 6 minutes normally. So it is going to be a subjective test. DLCO is objective. FVC is going to be decreased in all interstitial lung diseases. It will not tell about the progression. HRCT, again, it is going to show only honeycombing pattern. Okay, if it is here like this and here it is like this, means we cannot quantify the disease has progressed or not. Okay, because it is again varies from observer to observer, right? HRCT, I will read the HRCT like what I feel, another radiologist will feel in another way, right? So again, it is going to be subjective thing. So the answer here is going to be DLCO. Okay, single option here is going to be DLCO. A 70-year-old female, history of dermatomyositis, complaints of shortness of breath. She was never a smoker and has worked as a secretary in past. Her husband is a construction worker and they have parakeets at home. She has a family history of rheumatoid arthritis, diabetes mellitus, and hypertension. Based on the HRCT above, what is your likely diagnosis? What you will go for? So actually here, the patient has dermatomyositis and she has parakeets at home. Actually, this is even though she has dermatomyositis, whenever they give any kind of occupational history, because here the confusion is they have cellular non-specific interstitial pneumonia, fibrotic non-specific interstitial pneumonia. So both are actually non-specific interstitial pneumonia. Okay, so cellular and fibrotic you cannot see in usually in CT scan. You have to go for biopsy. Okay, so here we are going to rule out these two options. Parakeets. What is parakeets? Parrots. Okay, parrots. So whenever you use parrots, what is going to happen is you will develop sensitivity to the parrots. So answer is going to be here hypersensitivity pneumonitis. Okay, hypersensitivity pneumonitis is a better option here. That is also going to cause a pattern like this, which we will see later, which is called as head cheese pattern. Okay, we'll see later. Okay. A 55-year-old man, 30 pack years, current smoker, has complaints of worsening dyspnea on exertion, non-productive cough, bilateral ground glass opacities and centrilobar ill-defined nodules. PFT shows restriction with mild gas transfer defect. Surgical lung biopsy shows brownish pigmented macrophages in respiratory bronchioles. What is the diagnosis? It is going to be respiratory bronchiolitis, interstitial lung disease. A 50-year-old man, smoker, HIV, CD4 count 500, has been complaining of shortness of breath, non-productive cough for 5 months. He is previously treated with antibiotics, but its symptoms failed to improve. Okay, otherwise patient has crackles on auscultation. Okay, his WBC count is 16,000 and CT showed below. The cell count from bronchoalveolar lavage shows eosinophils 5%, lymphocytes 15%, neutrophils 15%. The transbronchial biopsy shows inflammatory intraluminal plugs consisting of granulation tissue with fibroblast and myofibroblast in connective tissue matrix in small airways, ducts, and alveoli with preservation of architecture and uniform appearance. What is your presumptive diagnosis? So I told you in transbronchial biopsy, there will be intraluminal granulation tissue with surrounding fibrosis, and CT scan will show reverse halo sign. Here they didn't give reverse halo sign. Atoll sign is almost like a atoll sign it is seen. Okay, so this is a case of cryptogenic organizing pneumonia. Okay, cryptogenic organizing pneumonia. So they have given directly the biopsy finding, right? There is intraluminal plugs by surrounding fibrosis. Okay, so that is what they have given here also, right? So interstitial inflammation with bronchial obstruction. So this should be a case of cryptogenic organizing pneumonia. A 62-year-old female comes to emergency department with complaining of shortness of breath and cough. She has a past medical history of multi-site low-grade monoclonal B-cell lymphoma, has multiple chemotherapies. She suffered a multiple chemo-related complications such as allergic reactions to drugs. She is having a saturation of around 83% on room air. Okay, and she is hemodynamically stable. And this is the investigation. What is your diagnosis? If I give the next page, it will be easy for you to diagnose. Okay, any clue here? Okay, we'll come to the next page. Neupogen was subsequently started. Okay, her leukocytes continue to improve. Okay, what should be the answer? Okay, so if they didn't give this bronchoscopy reveals, then what is the third box you have written? Secondary, what are the causes? Hematological malignancies. So she was having B-cell lymphoma for which she was started on treatment. So it is again telling it is a secondary pulmonary alveolar proteinosis. What pattern you see here? You can see crazy paving pattern. Okay, different colors in different areas. Okay, you can see one unseptal thickening is there. Okay, so this is a case of pulmonary alveolar proteinosis. What would be the appropriate treatment? It is bronchial lavage. That is the appropriate treatment. Okay, GMC supplementation can be an add-on treatment, but it is not so beneficial. Okay, according to trials. Okay, it can be a supportive treatment. Okay, so answer is high volume bronchial lavage. A 36-year-old female is referred to you for after release and admission for hospital for spontaneous pneumothorax. She reports 3 months of exertional dyspnea and trace hemoptysis prior to pneumothorax. Chest radiograph is given. What should be the answer? VGF is associated, right? I told you more than 800 is seen. You have to rule out mutation. Okay, so you have to rule out TSG mutation. Okay, to diagnose this patient, you have to go for TSG mutation. Okay, if they ask which of the following investigation will support in diagnosis or which can be a screening test, you can go for VGF. But VGF is increased in lot of conditions. Based on that, you cannot diagnose the disease. Okay, so answer here should be TSC mutation. Okay, what therapy has shown to stabilize the lung function and improve the quality of life in this patient? It is going to be sirolimus. A 55-year-old female presents to your clinic, okay, with 2 years history of non-productive cough, dyspnea on exertion. Review of systems also positive for dry eyes and dry mouth. Diffuse crackles are present in lung fields. Blood testing is notable for positive ANA ROLA antibodies? It is lymphoid interstitial pneumonia. A 39-year-old man presents to your clinic with dyspnea on exertion, cough and night sweats for 1 month duration. He has a history of 10 packed years of smoking. The physical examination is unremarkable. The chest X-ray shows ill-defined nodules with curvilinear reticular opacities. CT scan is shown below. This is a CT scan. This is the option. So here we have only 2 clues. One clue is smoker. Okay. Second clue is you see a lot of cyst. So what should be the answer? Langerhans histiocytosis. Answer is Langerhans histiocytosis. You have two clues here. One clue is smoker. Second clue is he's having lot of cystic or enlargement in the airways. So it is going to be more towards Langerhans histiocytosis. What would be the best next appropriate diagnostic test? So I didn't tell this. I thought I will tell here. So you have to go for next appropriate diagnostic step will be bronchoscopy with bronchoalveolar lavage. Okay. And what kind of tumor it is? It is a neuroendocrine tumor. Okay. Langerhans histiocytosis is a neuroendocrine condition. Okay. So what you will do? You will go for CD1A staining. Okay. CD1A staining. Okay. So in PLCH, ball fluid should be taken for CD1A stage staining. Okay. So again, I will ask you one more thing. Okay. In which condition you will take this fluid? Okay. And go for chromogranin, or you take biopsy and you will go for chromogranin staining. Small cell. Any other condition where you will get a Zeller-Ballen pattern? Pheochromocytoma. Okay. Pheochromocytoma, you will get chromogranin. So again, it is going to be a neuroendocrine staining. Okay. CD1A. Okay. So whenever you stain in CD1A, okay, you will get positive for CD1A. And whenever you take a biopsy, what kind of appearance you will get? Tennis racket sign. Okay. You will get tennis racket sign in PLCH. Okay. In PLCH also you can get tennis racket sign. Okay. So this is about the interstitial lung disease. Okay. So interstitial lung disease, what is important is, the first thing is what is the most common type of interstitial lung disease. Second is connective tissue disorders associated with interstitial lung disease. The third one is if it is going to be COP or BOOP, it is going to be having a transbronchial involvement with peribronchial interstitial involvement. Okay. Then you get atoll sign and reverse halo sign. Then next is smoking associated interstitial lung disease, PLCH pneumothorax, then PAP, 3 causes, and crazy paving pattern and treatment. And coming next to lymphangiomyomatosis, it is going to be seen in perimenopausal or premenopausal females. Okay, pregnancy accelerates the disease, and it is associated with VEGF, which is going to be increased, and there is going to be pneumothorax again, and treatment is going to be sirolimus. And next is lymphoid interstitial pneumonia. It is associated with Sjogren's, Epstein-Barr virus, and HIV. Okay, so overall, these are the important points in interstitial lung disease. And one more thing is, if there is an acute condition which is going to be Hamann-Ridge syndrome, which presents like ARDS. Okay, it is also called as acute diffuse alveolar disease. So it is again presents like ARDS, high mortality rate, and you have to put the patient on mechanical ventilation, where the CT scan is going to show consolidatory patterns. Okay, so this is overall the important points in interstitial lung disease. Okay, so if they're going to ask any question, this clue will be there in the question, and you can make the answer. I mean, you can select the answer correctly. Okay.